education city of Peradeniya from 1979 to 1985. There he earned distinctions in pediatrics and community medicine. He was awarded with the Van der Straten Gold Medal for community medicine and the Pannebukke Prize for forensic medicine. Subsequently, he obtained MD in general medicine in 1990. He underwent postgraduate training in pediatric cardiology at the Leicestershire Regional Centre in West Midlands and adult interventional cardiology at the Regional Cardiothoracic Centre, Walsgrove Hospital, Coventry in United Kingdom. He was board certified as a specialist in cardiology in 1993. Dr. Pramod Ranatunga was the General Secretary of the Sri Lanka Heart Association from 1996 to 1999 and the Joint Secretary of the Ceylon College of Physicians from 1990 to year 2000. He worked as a resident cardiologist at the Institute of Cardiology until his demise in 2005. Here he was instrumental in performing the first percutaneous coronary angioplasty and the first device closure of atrial septal defect and PDA in Sri Lanka. His dedication and commitment to provide an exceptional service to the people of Sri Lanka will be remembered for a long time to come. So I am happy to see Dr. Kumudini Ranatunga, our council member and consultant cardiothoracic anesthetist, and the beloved wife of late Dr. Ranatunga is here. Welcome you, madam, to the audience. And next, let me introduce the awardee, the winner of the award for Dr. Pramod Ranatunga Memorial Research Award. He is Dr. N.A.U. Disanayaka. Dr. Ajit Disanayaka is currently an international training fellow at the cardiology of Basingstoke and North Hampshire Hospitals NHS Foundation Trust, United Kingdom. And prior to that, he was the acting cardiologist at the National Institute of Infectious Disease, Sri Lanka. Now, today he is going to present us his work on the prevalence of cardiovascular disease and risk factor among hospitalized COVID-19 patients and their impact on the outcome. So, let me invite Dr. Ajit to proceed with his presentation.
Good evening. The President, Sri Lanka College of Cardiology, members of the family of late Dr. Pramod Ranatunga, distinguished guests, the Council, and the members of Sri Lanka College of Cardiology, my dear colleagues, ladies and gentlemen. I am greatly honored and privileged to receive the Dr. Pramod Ranatunga Research Award for 2021. I wish to thank the President, the Council and the Academic Committee of Sri Lanka College of Cardiology for selecting our research paper for this award. This is our research topic, Prevalence of Cardiovascular Disease and Risk Factors among Hospitalized COVID-19 Patients and Their Impact on Outcome. In background, COVID-19 became a global pandemic involving most of the countries and territories worldwide. It is caused by SARS coronavirus type 2. The spectrum of severity of COVID-19 varies from asymptomatic to critical illness. Most of the individuals are asymptomatic or may have mild disease. But some may progress to severe and critical illness with complications requiring hospital admission and special care. The global prevalence of non-communicable diseases also becoming higher. Sri Lanka as a developing Asian country that has high prevalence of cardiovascular diseases and cardiovascular risk factors in our population. As such, many of the COVID-19 patients may have these comorbidities when they present to the hospital. The prevalence of comorbidities in previous two coronavirus pandemics were reported as high as 10% in SARS and 30% in MERS. Emerging evidence shows similar findings for the current COVID-19 pandemic as well. and currently available data reveal the development of complication and severe disease is higher among COVID-19 patients with comorbidities with 10 to 15 times higher mortality rate compared to patients without comorbidities. There is association between COVID-19 and renin-angiotensin-aldosterone system. SARS coronavirus 2 use angiotensin converting enzyme 2 as a receptors to invert the host cell. RAS antagonists are also considered to upregulate the angiotensin converting enzyme 2 receptors. Therefore, there is concern that this upregulation may increase the susceptibility to COVID-19 infection. As we all know, RAS antagonists improve cardiac function, and also angiotensin converting enzyme 2 has a protective effect against lung injury. Considering these facts, the effect of RAS antagonists on COVID-19 infections may be either favorable or unfavorable. In this background, we designed our study. The primary objectives were to evaluate the prevalence of cardiovascular disease and cardiovascular risk factors among hospitalized COVID-19 patients, and to evaluate the impact of cardiovascular disease and cardiovascular risk factors on the outcome of hospitalized COVID-19 patients. In addition, as secondary objectives, we plan to evaluate the impact of gender on COVID-19 outcome, and in hypertensive subgroup, evaluate the effect of ARB and ACE inhibitors on COVID-19 outcome. We designed our study as a retrospective observational study and conducted at Colombo East Based Hospital Mullaeriyawa, which is the leading COVID-19 treatment center in Sri Lanka. And we conduct this study during the second wave of COVID-19 and included all the COVID-19 patients with confirmed PCR and admitted to Mullaeriyawa Based Hospital between 5th of October 2020 and 31st of January 2021, excluding pregnant women and patients below 18 years of age. The sample size was 200 and systematic random sampling method was used to select the sample. Ethical approval for this study was given by Ethical Review Committee of National Hospital of Sri Lanka. Administrative clearance was granted by Director Colombo East Based Hospital Mullaeriyawa. Pre-prepared data extraction form to collect the data from patients' BHTs. If we need further information or clarification, we directly contact the patients or their family members for those clarifications. Statistical analysis was done using SPSS Statistical Version 24. Before move into results, I would like to define some important terminology used in this study. Previously diagnosed cardiovascular disease, hypertension, diabetes, and dyslipidemia were taken as cardiovascular risk factors in this study. The term of cardiovascular disease include all the coronary artery disease, heart failure, arrhythmia, cardiomyopathy, valvular heart disease, stroke and TIA, peripheral vascular disease, and chronic kidney disease. The outcome of COVID-19 infection was evaluated based on following outcome parameters: the development of complication, requirement of ICU care, mechanical ventilation, inotropic support, multi-organ failure, and death. COVID pneumonia and ARDS were taken under the respiratory complication. Cardiovascular complication included myocarditis, cardiac arrhythmia, acute coronary syndrome, and thromboembolism. Myocardial injury was diagnosed by elevated cardiac troponin and or new ECG abnormalities with or without echocardiographic findings. Myocardial injury could be due to myocardial ischemia or myocardial inflammation. Patients with hypertension were further classified into three groups based on their antihypertensive at the patient present to the hospital. The ACE inhibitor group, ARB group, neither on ACE inhibitors or ARB group. These three groups were compared to assess the impact of RAS inhibitors on the outcome of COVID-19 infection. These are the strength and limitation of our study. Study sample population was consisted only with PCR confirmed hospitalized COVID-19 patient. Previously diagnosed cardiovascular disease, hypertension, diabetes, and dyslipidemia were considered as risk factors in this study. Even though this is a single center-based study, it was conducted in leading COVID-19 treatment hospital in Sri Lanka, which received patients from all over the country. So gave access to a large patient population for randomization. A prospective study posed some restriction in interviewing the patients with COVID-19 and also for follow-up for outcome. Therefore, we choose to collect the data retrospectively from patients' hospital record, ensuring the accuracy of data. Similar studies on impact of cardiovascular disease and risk factors on COVID-19 outcome are available from many other countries, but this is an initial study in Sri Lanka adding local statistics for comparison. Because there are several variables in this study, I would like to present our results under following category. The prevalence of risk factor will be present as overall risk factor prevalence and individual risk factor prevalence in different settings. Impact on outcome will be evaluated based on all the outcome parameters, including complication, ICU care, mechanical ventilation, inotropic support, multi-organ failure, and death for overall risk factors and individual risk factors separately. These are the socio-demographic characteristics of our sample. A total of 1,156 patients were admitted to Mullaria-based hospital during our study period. 200 patients were included in this study with the response rate of 100%. The mean age of study population was 47, ranging from 18 to 100 years. The majority were males with 55.5% of the male in our sample. First, we look at the prevalence of cardiovascular risk factors. The prevalence of any cardiovascular risk factor was 41.5%. Hypertension and diabetes were the most common cardiovascular risk factor with the prevalence of 29% for each. Cardiovascular disease 17.5% and dyslipidemia was 16%. Most common cardiovascular disease were coronary artery disease with 11%, followed by CKD 8.5%. When we compare the prevalence of overall risk factors on different settings, the prevalence of any risk factors among ICU patients were 76.2% compared to 37.4% in ordinary ward. The prevalence of risk factors in ventilated patients was 66.7%, and patients with inotropic support, it was 88.9%. All the patients with multi-organ failure had risk factors, and the prevalence of any risk factors among patients who died due to COVID-19 was 87.5% compared to the 39.6% in patients who survived. When we look at the prevalence of individual risk factors in different settings, the prevalence of each risk factors, including diabetes, hypertension, dyslipidemia, and cardiovascular disease, were higher in patients in ICU compared to the ordinary wards, and also higher in patients who died due to COVID-19 compared to survivors. After evaluating the prevalence, next we will evaluate the outcome of COVID-19. First we will look at the complication. At least one complication developed in 24.5% of patients during their course of illness. The respiratory complication was 15%, including 13.5% pneumonia and 9.5% ARDS. Sepsis or septic shock developed in 10% of patients. Cardiovascular disease, cardiovascular complications developed in 9%. Most common cardiovascular complication was myocardial injury with 8%, including 6% acute coronary syndrome. Development of any complication was higher in respector group compared to non-respector group. It was 48.2% in respector groups compared to 7.7% in non-respector group with significant p-value. The development of all the complication was significantly higher in respector group compared to non-respector group with significant p-value, except for the arrhythmias and thromboembolism. When we look at the arrhythmias and thromboembolism, all the arrhythmias and all the thromboembolism were occurred in respector group. So this p-value may be due to low incidence of those respectors in our sample. Considering the individual respectors, the development of complication were significantly higher in diabetes, hypertension, dyslipidemia and cardiovascular disease compared to its counterpart with significant p-value. When we move into the other outcome parameters, the requirement of ICU care, mechanical ventilation, inotropic support and multi-organ failure was higher in respector group compared to non-respector group, and the mortality rate was 10-fold higher in respector group compared to non-respector group. The mortality rate was 8.4% in respector group compared to 0.85% in non-respector group with significant p-value. When we move into the individual respectors and development of the other outcome parameters, the requirement of ICU care was 3 to 4-fold higher for all the individual respectors, including diabetes, hypertension, dyslipidemia, and cardiovascular respectors. And also, the mortality rate was higher in respector group compared to non-respector group for all the individual respectors, but significant mortality rate was seen in diabetes and hypertension. Next, we move into our secondary objectives, effect of gender on COVID-19 outcome. The development of complication was higher in male patients with 35.1% complication rate in males compared to 11.2% complication in females with significant p-value. Similarly, the ICU admission also higher in males compared to females with significant p-value. The mortality rate was 5.4% in males compared to 2.2% in females, but the difference is not statistically significant. When we assess the hypertensive subgroup, out of 58 patients with hypertension, 18 were on ARB, 13 were on ACE inhibitors, and 27 were neither on ACE inhibitors nor ARB. The development of complication and need of ICU care was lower in ARB group compared to other two groups, and also there was no death reported in ARB group out of the 18 patients, but mortality rate in ACE inhibitor group was 7.7%, and neither on ACE inhibitors and ARB group were 14.8%. But these differences are not statistically significant. So this study confirmed the high prevalence of cardiovascular disease and cardiovascular risk factors such as hypertension, diabetes, and dyslipidemia among hospitalized COVID-19 patients in Sri Lankan population. The highest prevalence was observed in hypertension and diabetes, followed by cardiovascular disease and dyslipidemia. The commonest cardiovascular disease were coronary artery disease. The significant higher prevalence of risk factors were observed in ICU patients and patients who died due to COVID-19. The prevalence of cardiovascular disease risk factors were higher in patients who required mechanical ventilation, inotropic support, and those who had multi-organ failure. These findings are compatible with reported data on the prevalence of these risk factors in previous to coronavirus pandemic, SARS and MERS, and also available data for the COVID-19 infection from the other countries. 1 out of every 4 patients develop at least one complication during their illness. The most common complication of COVID-19 infection was respiratory complication, followed by sepsis or septic shock and cardiovascular complication. COVID pneumonia was commoner than ARDS. Among cardiovascular complications, myocardial injury occurred in 8%, including 6% acute coronary syndrome. COVID-19 infections may increase the risk of acute coronary syndrome by increasing the risk of thrombosis due to deranged coagulation system and increasing the risk of plaque rupture by overt inflammatory response. The development of any complication at any point of the illness was significantly higher in patients with cardiovascular risk factors compared to patients without risk factors. Complication rate was significantly higher in patients with hypertension, diabetes, cardiovascular disease, and dyslipidemia compared to their counterpart. These findings confirm that cardiovascular risk factors are associated with development of complication and severity of COVID-19 infection. Death due to COVID-19 infections was tenfold higher in patients with cardiovascular risk factors compared to patients without risk factors, and the comparative findings were reported in previous coronavirus pandemic SARS infections with 12-fold higher mortal rate in patients with comorbidities. Death due to COVID-19 infections were significantly higher in hypertensive patients and diabetic patients. The development of any complication was significantly higher among males compared to females, and males need more ICU admission than females. Although 75% of deaths were males, mortal rate was not statistically significant in males compared to females. In subgroup analysis of hypertensive patients, the development of complication, ICU care, and mortality were lower in patients taking ARB compared to other two groups. This unexpected finding was statistically not significant, most likely due to small sample size in our subgroup analysis. Therefore, this area needs further study with the larger sample size to evaluate the effect of RAS antagonists on COVID-19 infection. In conclusion, the high prevalence of cardiovascular disease and cardiovascular risk factors such as hypertension, diabetes, and dyslipidemia were observed among hospitalized COVID-19 infected patients in Sri Lankan population. The prevalence was higher among ICU patients and patients who died due to COVID-19 infection. Overall, CVD risk factors were associated with high complication rate and severe disease requiring ICU admission, mechanical ventilation, and inotropic support. The presence of CVD risk factors significantly increased the mortality among COVID-19 patients. Considering the individual cardiovascular risk factors, each were associated with significantly high rate of complication and severe disease requiring ICU care. A statistically significant higher mortal rate was observed in hypertensive patients and diabetes. Male gender was associated with significantly high complication rate and ICU care, but no statistically significant difference in mortality. ARB showed a possible protective effect on complication and outcome of COVID-19 infection in hypertensive patients, but this needs further evaluation with studies with larger sample size. In acknowledgement, my heartfelt thanks goes to Director and other staff of Mullaria Base Hospital, our research team, Dr. Chemali Kerihettidiyana, Dr. Yashani Madhurika, and Dr. Indika Gunawardana, and especially to my clinical supervisor, Dr. Gamini Galapatti. Thank you.
Thank you, Dr. Ajit Disanayaka, for doing that very important study to establish the association between cardiovascular risk factors and complications of COVID-19 disease in Sri Lanka. And actually he left a very good research point of highlighting the possible differential effect of RAS inhibitors, the possible protective role of ARB. So that's a very important point that needs investigations. And Dr. Ajit is awarded with a medal and also a cash prize from the Sri Lanka College of Cardiology, but as he is joining virtually and he is currently resident in United Kingdom, we will send them to him in due course. And I think we will wind up for the day, and thank you very much, Ajit, for that wonderful presentation.